So, thank you very much. Can you hear me okay there? Thank you very much for inviting me to speak today. The last time I spoke with Andrew, straight after Andrew, is burned in my memory because we were in a debate. And it's probably faded into his memory because he became first. And the reason it's burned into my memory, I was straight behind him in second. So the natural order of things still holds place, so it does. I want to tell you about, a patient that I used to visit. And the reason I want to tell you is I literally passed where I met this patient first as I was cycling to the train for Galway. And this person, I didn't know his name. And he used a particular technique, which I call the natural technique, the natural method, to keep people away. And that brings me to a separate story as to why I call it the natural method. And it goes back to when I was in the Coombe Hospital. And at the end of when you're an SHO in the Coombe Hospital, when patients had delivered, at the end, you'd always have to ask them after what form of family planning do they intend to use. And I remember one particular woman saying to me, she said, "Oh, Jay's doctor, don't talk to me about family planning." And I said, "Why?" She says, "I used to use the pill, but I got pregnant on that." And she said, "Then I got to use the condoms and it burst, and I got pregnant on that." So I said, "So what are you going to do now?" She said, "I'm going to use the natural method." And I said, "The natural method?" She says, "Yeah, I tell him to fuck off." And the reason I say this particular patient uses the natural method was this is sometimes a technique that some homeless people use to just keep their space clear. They just say, "Fuck off, fuck off." And this particular guy, every time you'd approach him, he was an older man who you'd approach, and he would just say, "Fuck off, fuck off." And me and a group of key workers went to him for several years, and every single time he'd do the same thing, and we could not make contact. He slept in a particular doorway and got lunch in Merchants Quay, Ireland. And then one year we became quite worried because there was a fight on at lunchtime, and during the fight he got fright, and basically he stopped going down for his lunch. So next thing we thought he's not getting food, and we thought he was getting weaker and weaker. He was in around his late 60s. And we never got to know his name, nothing about him. And we started going back, offering him food, and he again just say, "Fuck off, fuck off." And I even approached him as a researcher at one stage and was told, "Fuck off, fuck off." So we were but he was losing weight, and one day we went to him, and he again said, "Fuck off, fuck off." We started walking down, and I just went back and I said, "Listen, is there anything you want? Forget if it's a doctor or mental. Is there just anything you want?" And he looked at me and said, "I'd love a haircut." So he said, "Well, we'll get you the van and we'll bring you down and get your haircut." So I sent someone off to get to a to a pharmacy to get a shears and a scissors. And we brought him down to the local Capuchin food hall. And while he was waiting for the haircut, we got him clean clothes and we gave him a haircut. I gave him a haircut, and it was the worst haircut you've ever seen in your life. And he got some food, and we brought him back to where he was staying. And as we brought him back, he said, "I don't want to go back here." So we brought him to hospital, and he sadly died a week later. And we got his name before he died and his history. And that's relevant to what I want to talk to you about, because the reason I'm here is that I was talking about patient involvement, and people were talking about doing research with marginalised groups such as homeless. And I sort of wanted to tell you about my research with homeless people, both to make you understand why it's so difficult to make contact with homeless people, both as a researcher and also as a practitioner. Because that was the focus of my research. It was trying to find out, why do homeless people not use health services as efficiently as they're supposed to use them? So if you were to provide a health service for one group of people, it would be homeless. Myself and Fiona Riley and Anne McFarlane as well, amongst others, conducted research both in 2005 with myself and Fiona, and then we repeated with the other group just around 3 years ago. And for example, 1 in 3 homeless people has hepatitis C, 1 in 20 have HIV, 1 in 20 have hepatitis B. They have very high rates of COPD, diabetes, epilepsy, higher than normal rates. 1 in 2 have depression, 2 out of 5 anxiety, and 1 in 3 have attempted suicide at some stage in their lives. So if there's one group of people you want to use health services, it's homeless people. But using, of course, Tudor Hart's inverse care law, those people most need services are least likely to get them. That's the same with homeless people. So I decided I'd conduct ethnographic research. And I was doing it through the University of Bath, which someone here, Laura, is working. As you met her this morning, she's over there at the moment. And it's a professional doctorate I did over there. And I particularly chose ethnographic research because I wanted to find out. Grounded research or qualitative often looks at people's intentions. What do they intend to do? And quantitative research looks at what they actually do. Ethnographic research allows you sit and observe when people are both telling you what they intend to do, but you can actually see what they do. So it allows you to see them where at the time when they both see intention and actual behavior at the same time. And so that was one of the main reasons I decided to conduct ethnographic research, and also as a way of getting to the heart of why homeless people were so disempowered in this area, which ethnography is particularly good at. So I actually did it for a half a day a week for 15 months at 4 different sites, food halls, a outreach service to the homeless people, and 2 drop-in centres. On top of that, I did 47 semi-structured interviews, and I ran 2 focus groups as well. The epistemology was critical realism. Critical realism straddles between constructionism and realism. So, and the reason I chose that was, in a sense, homelessness is a constructed entity. And what I mean by that is, what is homelessness? It means lack of a home. Well, does that mean lack of a roof? Most homeless people have a roof because they actually sleep in hostels. Does it mean lack of a home that's your own? Many people live in homes that's not their own. Does it mean lack of a place of safety? Many people live in homes where they don't feel safe. So if you actually try and deconstruct homelessness, it is very hard to define a clear entity called homelessness. But for me, most importantly, I work in the inner city. And I would meet patients in my practice in the inner city. And then I also work in hostels for homeless people in early morning. And a few months later, I'd be in one of my hostels and I'd meet the same patient. And then 6 months later, I'd be in my practice and I'd meet the patient again. And that's because a lot of people move from homelessness to their homes. And in fact, where I see homelessness now is the far end of poverty. It's the cliff that's at the edge of poverty. So it's a constructed notion, but there's a significant reality to the existence of what we call homelessness. And critical realism recognizes that a lot of what we see as reality is constructed, but says underneath it there is a reality, and part of what critical realism, it tries to recognize and define what that reality is. And the particular focus of critical realism is to define what happens at the generative level. When the generative level is what generates the actual events and things that happen that happen in reality. The actual level is the events themselves that we see occur in front of us, and the empirical level is how we experience those events. So in trying to do the research, you're trying to go through your own experiences and put aside your perceptions that are the elements of your perception that are clouding what's actually happening. And then from identifying what's actually happening, you're trying to identify the generative causes of that. So I'm going to go through the research, and then I'm going to go through some elements of the methodology. And then I want to finish up with what I think is really important about research is, and I think it's very important, I know this about patient involvement, this research didn't involve patients as such, but I think it's critical that whatever you produce results in improvements for patients, and that the patients know that the research resulted in those improvements. So, just to say, in the research I found out what is well known in the literature, homeless people will wait and wait and wait till the actual symptoms of the condition they have is overpowering. I was out on Monday night in our homeless outreach mobile health unit, and we met a woman who has a massive abscess in her groin, and she has a mild infection in her other groin where she injects, and she's still injecting into the mildly infected groin and not through the abscess. She wouldn't go to hospital because she says she'll be fine. She isn't that bad at the moment. I mean, it's a massive abscess. It looks horrific. Secondly, homeless people will default from treatment. They often will go for a few outpatient appointments and then they disappear. They will go into casualty, get some of the tests and then leave. They classically will go into hospital. Will I stop it? Or keep going? They classically will go into hospital and they wait they'll go in, get treatment, and then when they start to feel a bit better before the treatment's completed, then they actually end up leaving before the treatment is completed. And in fact, there's been research done in the UK where they actually did programs to try and get people to stay long-term in hospital. So they actually succeeded and people stayed longer, but by staying longer, they actually found they reduced the number of bed days for homeless people in hospital that year. And the reason being is by staying longer, they got cured, whereas what was happening is they were leaving before the treatment was completed, and then they were coming back a few weeks later because they needed to get readmitted. Homeless people often classically what to do is they don't use primary care services, they tend to avoid GPs. And they often use high, often described as inappropriate, and I have to credit Andrew because you often once in one of your articles previously said that inappropriate is a wrong term because it's a term that's defined by the service providers. But they tend to be high users of emergency departments, and many of them actually sleep in emergency departments, which I think is a very human response. And I don't know if you saw in Tala, they found a man who was dead recently, and I felt very sorry for Tala Hospital because they were checking people in. They knew he slept every night there. He slept during the actual snow. He probably would have died in the snow if it hadn't been for emergency department. And then they're criticised because they did that and he happened to die in his sleep. I mean, of course that happens in a busy emergency department where you're letting someone sleep. They have poor compliance with medication and they tend to avoid psychiatric services because they have bad experience of psychiatric services from their perspective. They tend to find compulsory admission they tend to try and avoid that, or avoid going on psychiatric medication. So I'll come back to, this is the model that I devised for my research, but I'm going to describe the elements of the model and I'll come back to the model in the end. So first of all, I identified that there were a number of, I was trying to figure out why do homeless people act this way? And I very much went down a concept of what I call the barrier model. And I tried to identify a number of barriers. I did identify through the research a number of barriers that prevent homeless people using services. And I devised these into external barriers and what I call internalized barriers. First of all, I just go to external barriers. These are barriers that exist in the system itself. So physical barriers. Distance is not a barrier for someone who's got a car or can afford to get a bus, but is for a homeless person who can't afford to travel. And many homeless people, even if they do have medical cards, live in the inner city because of hostels, and their GP is out in Coolock, which is 4 or 5 miles away, and for them it's too far to travel or they can't afford to get out there. If you don't want a homeless person to use your service, give them a form. If you really don't want them, make the form as complex as possible. And what we have, medical card application, is an incredibly complex form. And that's why in 2005 we found, even though every single homeless person is entitled to a medical card, 45% of them didn't have a medical card in 2005. We've put on a program really trying to get homeless people onto medical cards. In 2014, we found that 75% had a medical card. But still, they still roll out the same medical form. Appointments. First of all, hospital appointments are still sent out regularly to homeless people. Every week I enter at least 20 DNAs as letters into the actual system we have for keeping records of homeless people. Not only is it not, crazy sending them out, but even giving a home appointment to a homeless person who doesn't keep diaries, doesn't have a sense of time in their day the way we do, doesn't have the structure. Some of them are changing hostel every night. So how can you expect them to keep an appointment? Appointments are designed for middle-class people who have telephones, diaries, and methods of organising themselves. Queues. Absolutely, it is very difficult for all of us, and we all have to stay in a queue. But the reality for homeless people, in my waiting room, where I have in the hostel, you'll find homeless people come, they'll sit up, they'll get up and walk around. They tend to hate sitting down for long periods of time, and they like to move around. So queues are very difficult for them, and often means that they leave early. If they see any form of a queue, they just leave. In emergency department, it's routine that you don't give methadone or Librium to patients who are addicted to either if they're in the waiting queue. And the amount of phone calls I'd ring up and say, listen, this patient's really sick, and if you put him in the queue, he's going to go into withdrawals, which they would, and they'd go out either to get an alcohol or some heroin, and then they come back in, and they were told, go back at the end of the queue. I call it the never-ending queue. And they would still say, we can't break the rules even for homeless people. Rules of service. Rules of service are there to help keep health and safety, and I recognise that. However, you've got to recognise most homeless people come from homes or families where rules were enforced with stick and fist or aggressive shouting. So for them, the way they respond to rules is the same way they responded as children, which is to kick off. And so then what happens? They get kicked out. And this is a person who said that he had been punished because he was using drugs. And he said, I'm a drug addict, for fuck's sake. You know, it sounds so obvious. So rules of service, I'm not saying we need to recognise that you need to keep health and safety for staff, but we find in our service we tend to be more flexible about rules. We tend to have methods of managing to calm people down, to get them to do what we want them to do, rather than just enforcing the rules. We try and persuade rather than force. If we do bar someone, 2 weeks ago I had a woman who was pulling another person by the hair in my waiting room, and we got her out the door and said, you have to go down to Merchant's Quay now for the next 6 weeks and then come back to us. But she's going to get a service at Merchant's Quay. So even though we do bar her, she's going to another service and then she'll come back to us. We don't make it permanent. Presence of absence of information, obviously an issue for all people, particularly homeless people, and particularly with homeless people where there's high rates of illiteracy. Stigma and discrimination. John and Anne are two patients of mine, and they tell this story. They used to be asleep in Stephen's Green where they were on crack, heroin and alcohol. And they tell this story of how one Sunday it was raining, one December, they were freezing cold, there was no drop-in open, they wandered around, and eventually he was becoming unwell, so they went to casualty, and he actually started going unconscious in casualty due to hypothermia. As the doctor was cutting off his clothes, he turned to Anne and said, "This is disgusting, the condition you both have got yourselves into." Anne has said she will never go back to a casualty unless she is absolutely dying. And there's two problems about this. One is that she won't go back to casualty unless she's dying. The second problem is that same John and Anne went into our mobile health unit where they met a very nice GP trainee who persuaded them to go down to get treatment on methadone. We started them on methadone. We got them into the Simon alcohol detox. They now both are alcohol, cocaine and heroin free, living in their own accommodation and both doing pre-university courses. So that doctor didn't only force that patient not to come back, he lost an opportunity to make that same intervention. So it's the double whammy of stigma. And stigma was a huge issue for homeless people. I won't go into it, but I also identified what I call conversations of exclusion. I'll just briefly mention two. One is called the benzo conversation. This was a repeated conversation that resulted in homeless people not accessing services. The benzo conversation is, "Doctor, I need some tablets." Doctors are thought that bad doctors prescribe benzos. We're constantly told it by the medical council and other people. So doctors take slight offence at this and say, "I don't do those benzos." And the patient who will go into withdrawals and possibly fit if they don't get their benzos, say, "Well, why don't you do the benzos?" And they say, "Don't speak to me like that." And the conversation degrades until one charges out the door, slams the door behind them, or becomes aggressive, and the doctor then ends up having any sense of stigma reinforced. The mistrustful conversation, that's where a doctor is told a lie and says, "I'm never going to treat you again." That was a frequent occurrence. I think doctors have mistaken relationships between patients as the same as amorous relationships. If I'm in a relationship with a partner, I need to trust them. I don't need to trust a patient, particularly patients who are forced by our system to tell lies to get what they think they need. I disagree with what they need, but they think they need it and they tell lies to get it. So I don't take offence at patients telling me lies. And further, I find it very releasing on occasions when patients say, "Listen, I need to go down the country. I'm going down to visit my parents. Will you give me a takeaway?" And I say, "Listen, will you give me a letter?" And they say, "Why?" And I say, "Listen, I know you're probably telling the truth, but the problem is I know this system forces people to tell lies, so I often don't know who's telling the truth or who isn't, so I need the letter." And I find it releasing to be able to say the truth rather than pretending, "I know you're telling the truth, but I just need the letter," because then you get into this ridiculous argument. The blaming conversation, that's you're at fault for your problem, and the assertiveness conversation is, I met this guy when I was out doing the research who had chest pain. And I said, "You need to go to casualty." And he said, "I've just been." And he said, I had a row with him. I said, "Jump in the car." We went to casualty. I went up to the reception. He went up there and I said, "Now, give them your name and details." I sat down. 2 minutes later, they were having a row. And I went running up and said, "What happened?" And I realized that he was trying to assert his desire to get into thing in the way he knew how to assert himself, which is to get angry, where I was able to say, "Excuse me, I apologize about the way he behaved. My name's Dr. Austin O Carroll, and I think this man needs to be seen urgently, because I can assert myself in a middle-class way." And that's the assertiveness conversation, and that often leads. So these are conversations that lead to breakdown between doctors and patients. External barriers are bad. Internalized are the most effective barriers of all. What's an internalized barrier? An internalized barrier is where you have internalized the message from outside and you end up not even presenting to the service. So go back to Anne, who I told you, when she was told by that doctor, you are disgusting the way you got yourself into, she said, I am never going back to that service. That's the internalized barrier. So if you have a fantastic service that you have managed to get the message across to we don't deal with drug users or homeless people, then you will not have them presented and you will say, well, I don't bar people because you've got the message across. That's the internalized barrier. It's the most effective barrier of all. And I identified a number of internalized cognitive barriers. That's thoughts or emotional barriers. So the cognitive barriers, fatalistic cognitions. If you think you're going to die young, why bother taking care of your health? One guy said to me, he said, I'm at a stage where I have no family and kids and I have no job, I'm 35, what's the point in going on or taking, what's the point about it? So, and why would homeless people think they're going to die young? Because all the evidence shows that they will die young. Denial cognitions, I leave it, I'll be fine. I have a patient who has gangrene at the moment, who needs to have that treated urgently, but he says, I'll be fine, just leave it. It has been for the last 6 weeks. The presumption of poor treatment, which is also the same as the presumption, similar to the presumption of discrimination. If I go down there, they're going to treat me badly. If I go down there, they're going to discriminate against me. Self-blame cognitions, that's where you've actually internalized the inhibitors so effectively that you actually say, well, it is my own fault. So sometimes you feel like you're wasting their time, that somebody's out there who has more. Obviously, I've self-inflicted this with drink or alcohol. I obviously believe myself personally that these people don't inflict this. I don't believe it's individualistic fault. I think it's because they come from poverty and oppression and we have an unequal society. But they believe the individualistic arguments that it is their fault, that they're the agents of their own terrible situation. Similar to denial is deferral to the future cognition. I'm going to leave it to the future. The need to survive cognitions. This is actually recognized in the literature as competing priorities. If you were to do Maslow's triangle for drug users or alcoholics, you'd have drug and alcohol at the bottom of the triangle. Because that's the first thing they need to do when they go out in the streets is get money for drugs or alcohol. And then they need to get a home. And then they need to get their clothing grant or their social welfare. And going to a health service is way up that triangle. So a lot of them need to survive. So getting to a health service is way down their priority list. Now, there was also emotions. Fear. So this was a really interesting one, and it's an issue that if I have time I can address, is that violence and aggression is endemic in homelessness. It is a very, very violent place to be. I think 2/3 of women in homelessness end up suffering sexual violence. Physical violence is just endemic. And a lot of homeless people avoid services, say particularly methadone clinics. They won't go to that methadone clinic because they're having a fight with the person over there. Or they'll avoid that pharmacy because they'll be passing people, or that particular doctor because there's people right there to get them. And really interesting when I discovered a lot of homeless people deliberately look aggressive because that's a way of keeping yourself safe. And that was actually a real learning point for me. Lack of fear. I would be terrified to get an HIV or hepatitis C, but when you've 1 in 3 or 1 in 20 of the people you mix with has HIV or hepatitis C, it strangely enough makes you not fear so much that particular disease, so they're more likely to take risks or seek treatment. I sent 40 people for treatment. The treatments for hepatitis C that will cure hepatitis C in 95% of cases. I sent 40 people and 23 missed their appointment. Hopelessness, I don't care about my life. Embarrassment, the idea that a lot of people, because they feel they know they look unclean or they smell and they don't want to sit in the waiting rooms of GPs. Low self-esteem, and as I said, that's internalized by the stigma, the discrimination, and the general lack of anyone giving them positive reinforcement. Anger, as we talked about in terms of assertiveness. By the way, someone's going to need to keep me on time, so give me 10 minutes eventually, because I have a lot going through and I'll cut things off. How far have I got to go? Oh, crap, well, I'll move on quickly. So this is the model I came with, basically, and the step, this is the pathway you take towards going towards homelessness. And as you go along this pathway, you vary things. You identify a healthcare need, and then you go on to healthcare seeking, healthcare reaching. And basically, these various barriers prevent that pathway from identifying a symptom. Only, I think it's 1 in 20 of symptoms actually make it to the doctor. For homeless people, it's much worse. I'm going to flick through the generative mechanisms. These are the things that cause, they were the things that occurred, the occurrences at the actual level I was talking about, that I was trying to identify. What generated these? Well, first of all, as I felt, prior to becoming homelessness, poverty was one of the big generative factors. Poverty causes lower expectations, family dysfunction, how you can't manage assertiveness, etc. Substance misuse from your background, fear of authority, illiteracy. Mental health is a separate issue that occurs before to becoming homelessness that causes a lot of these factors. And then a second generative group of mechanisms came after being homelessness, and was the nature of homelessness itself, the lack of appropriate accommodation, the ubiquity of permanent early death, media priorities prioritise the chaotic nature of homelessness, your negative experience of authority of police, of social workers, etc., that causes you to fear authority and stigma and discrimination. I'm going to skip this here. I'm going to suppose one of the big things that I came out of this was that, in fact, we have designed health services for middle-class people who have homes, houses, cars and telephones. We haven't designed them for homeless people. If you were to design a health service for homeless people, it would be open 24 hours a day. You would be able to be warm, it would be friendly. You would be able to get both hospital and GP treatment in it, and you'd be able to sleep there. A casualty. Hence, it's not inappropriate for homeless people to attend casualties. Obviously, one of the things I've done, and I'll come to it now in a second, is we've designed services for homeless people. I'm going to flick through these things. I want to get through to what the actual thing we did with the research, but that was the issue of positionality. If anyone wants to talk to me, or also I identified a number of skills for approaching homeless people when you want to make contact with them as a researcher. Prior to actually starting, I had working in homelessness. So prior to starting in homelessness, I had found a safety net. But I have to say the research totally changed the way we've delivered safety net, because my findings in the research became that, you know, there's two ideas. Do you integrate homeless people into general practice, mainstream, or do you just provide what are called specialised services? Mainstream services are not designed for homeless people, and there's such a huge element of barriers, external and internalised, and there's so much stigma and discrimination. I think it's impossible to use mainstream services at the moment. It would take fundamental change. So I see myself as adapting my service in the inner city to provide an extra service that meets the needs of homeless people. So I don't see it as a specialised service. I'm disabled, so I hate the term special. So I do a service where I go out to homeless people, which is adapting my service. In Foxrock, which is a wealthy area in Dublin, people go into city centre at daytime to work, and so they have nighttime surgeries. And that's not normal GP practice, but we don't call it specialised services. We call it just an adaptation of your general practice. So I adapt and we provide these services. We go to hostels, food halls. Safety Net both provides direct services. These are the hostels that homeless people, it has a team of doctors and nurses that go to these practices. And we also, it supports affiliated services in a number of ways, through governance policies, and also through a combined software program. Basically, and if I go to the Capital Clinic and see a patient, and another doctor sees them in the Granby the next morning, they'll see the same records and they know what medication I gave them, so that improve safety. We actually see 6,500 patients per year at this stage. I want to mention just some of the services we provide. We provide a methadone service, we provide a TB and hepatitis screening service. We also do run a service for HIV, people who are homeless with HIV, a stabilisation unit. We actually, because we got used to providing services for homeless, the HSE came and asked us to provide service to other marginalised groups. We have several clinics now for Roma and also for undocumented migrants. And we also run a mobile health screening unit that goes around to help integrate the Syrian refugees into general practice, as well as other migrants as well. We run a benzo detox and alcohol detox. We run a specific diabetic service and an epilepsy service for homeless people. We run a street medicine conference every year, including hosting an international one. Our mobile health unit goes out 4 times a week that to specifically get to rough sleepers. And then the hepatitis C service. If I could mention the example of how we have used the services. The mobile health unit was actually developed in response because we recognised a lot of homeless people weren't using when I went out to the streets, I met a lot of homeless people that weren't using our fixed site clinics. So we developed a mobile health unit to get out to those people. I told you about the hepatitis C program. That's a program where I sent 40 people for referred them to hospital, and 23 missed their appointments. So we have now got in touch with the hospital, and now we gave them a GP trainee from our GP training programme. That, 5 minutes, thank you. That GP basically runs a service, the hepatitis C service, and now we deliver the actual treatment. They get it with their methadone, and they get it in local pharmacies as opposed to having to go to the hospital. So they have reduced it from 7 hospital visits to 1 hospital visit, which we get a peer worker. We now have recruited a group of peer workers who are homeless themselves, and we've trained them up to actually bring the homeless people to the hostels and the appointments. And we have all 40 people now starting on treatment, and we have 60 others waiting for treatment at the moment. So that's a very successful, and that came from recognising that homeless people don't use appointments. Our epilepsy service was because homeless people didn't attend the epilepsy service. Our diabetic service was the same thing. So a lot of the actual stuff we did was actually in response to the findings of the research. As Andrew said, I also found the North Dublin City GP training, and that was very much influenced by, it specifically seeks to train GPs to work in areas of deprivation and with marginalised groups. That's our mission. We run a curriculum and have I'm going to flick through these. In the last year, for 1 day a week for 4 months, they work in homeless services. For 1 day a week for 4 months, they work in drug service. And 1 day a week, they work in prisons in the morning and migrant services in the afternoon. We have the highest amount of applications of any scheme in the country. When I first started, people said, don't call it that. I said, why? I said, no one will apply. Every year we've had the highest amount since we started. That shows to me that young people do want to make a difference. We tend to be cynical about that. We have actually had a national social medicine module, migrant health module. I've just done a survey, literally got it back 2 weeks ago, and of the people who responded, 88% responded, and 95% are working in social medicine or deprivation, and all of them say that's where they want to end up working. In fact, there's a similar scheme started in Manchester, and Glasgow has started a scheme based on our model up there as well. And that was very much influenced by the idea of the results of the research. And I suppose that's what the emphasis is, that your research needs to feed what you do. And the research I did not only fed the work I do in terms of helping develop services, I actually found really interestingly, having worked as an ethnographer, and there's the whole issue of positionality, me as a doctor versus an ethnographer, it's transformed my method of interacting with homeless people. I'll go on the street and sit down and talk to someone, because that's part of the research. I had to sit down on the street and talk. And I find if you sit down, you get a much better relationship. I find myself much less judgmental having been with them. I'm much more tolerant of behaviours than I had been. And also, I think I've developed a series of skills for interacting with them that I wouldn't have had before, which means that they don't tend to get aggressive, and they tend to stick with me and stay more loyal to me. And I think, interestingly, that's one of the outcomes of the research that is uncaptured as such in research findings. I think I've finished up on time, so I'm going to finish now there, but I have issues on the idea of positionality, if anyone's interested in that. I also have safety skills for people working in homelessness, and anyone wants to go through that. And last of all, I have a little bit about communication skills and making contact with homeless people. Thanks very much.